Sorry for the delay. No one is born knowing how to tie a perfect surgical knot, and thankfully, no one expects us to. Stepwise training is what turns our shaky first attempts into smooth, confident moves. To talk about building confidence before competence, I am delighted to invite Dr. Sheetal Savar to the stage.
Good morning, everybody, and thank you for this opportunity. So I will begin with this topic. Perhaps it's a bit of overlap between the other topics that were there in the morning. So it kind of might seem like a summary to all of you. How do I change the slide? This one, right? Okay. Yeah. So like Sarita said, the PGs in ophthalmology, after a great battle, would have cleared their NEET and landed in their dream specialty, hopefully. And after this, it's like hands are itching to operate, and they've gone for a very long distance camp, seen so many patients. One of them will be Mr. Duja Pujari, okay, who's blind as a bat. And the unfortunate part is he's lost many members of his family in some bus accident, and it's only his little grandson who's there with him. Okay, so this PG manages to convince him and bring him for surgery, one of the camps. Now this is the postgraduate who's very happy that the patient has landed in his hospital, and he's like drooling and waiting to operate. He's dreaming that next day he's going to get a full case. Okay. But this is the teacher, okay, in a dilemma because this PG is working hard, yes, convinced and got the case, but he's not been doing his wet labs. He's not seen him suture, so he's not very sure. And he also knows that adults with blindness have 1/3 shorter life. That means if Duja Pujari was to live for 90, he might only live up to 60 if there was a complication of this surgery and he landed in blindness. Also, young children drop out of school many times in, in many smaller places to care for the blind. Oh, I did something, yeah. Now, let's look at another perspective. Okay, this is for the PG. Imagine you are the patient and you are your own surgeon. Would you want to operate? What kind of competence would you expect a surgeon to possess? Can you achieve that level of competence? So let me just here describe to you what competence means. Surgical competence is the ability to apply knowledge, skills, and professional attitudes effectively and consistently to perform surgical tasks and manage patients in both familiar and new situations, leading to acceptable clinical outcomes. So, acceptable clinical outcome, please remember that. So how should one go about this is perhaps been covered. You have to read books and not small guides. You have to read the most descriptive book for surgery. Then, of course, there's no dearth of online material. There are online videos. Some of, I've put up very good lectures are there. Then there are some websites like CyberSite. So there's no dearth of material. Next is to understand the tools. Okay. So as in the earlier talks, it was mentioned, it's not okay to just go and operate. You have to know how your microscope works. Many times I realize my PGs, they don't know how to zoom, they don't know how to focus, but they all want to operate. Okay. Also, you must know which instrument is, for which step. The surgeon should not be asking you, give me this, give me that. And you should know how each surgeon wants his instruments. Also, asepsis and the correct scrubbing technique, that also one has to concentrate on. Next is to understand the mechanics. So again, this was described, you have to watch and observe very actively. You observe many senior surgeons performing because each one has a different approach, Okay, and you never know what might be useful to you later. So observe all this and also understand the surgical process and how surgical teams work. Now, nothing is ever too small in surgery. So some of these things I'm telling you is what our PGs have done in our institutions right from COVID days. Until then, wet lab was not so active. Okay, after that, we all got desperate to teach them and they were also desperate to learn. So we actually started with all this. We have tried so many different vegetables and fruits. So some of the steps that you can practice is making an incision. You can do a tunnel. You can practice capsulorhexis. So you blanch a tomato, half boil a potato. You can use an apple, you can use a plum, you can use a grape. So there is no end to it. Just be innovative. You can use anything to practice. And surgery is a craft. So working on the skill really helps. This has also been spoken about. So we started with any eye that we got, goat's eye, porcine eye. And we started like this. These are our pictures during COVID time. And we didn't really have artificial eyes at that point in time, but they're also available now. Then we were innovating and we started using smartphone magnification so that they can use both their hands. Then we started using the surgical loop. Some of our PGs you may recognize. Then we started using the microscope also. So now you would ask, are they really useful? Yes, there are studies to show. One of them done in India says, there's a 52% reduction in PCR rates when trainees underwent skill training in the wet lab. Also, there's a randomized control trial that showed using synthetic eyes for simulation training in SICS doubled the confidence of trainees and reduced complication by 72%. So there is enough proof if someone wants to know. Okay, this I'm not showing because everyone has been showing this picture. So we know that simulation is very important. Perhaps we are going to get one of them in our neighboring colleges soon. Okay. So the advantages also has been described, you know exactly the depth of the dissection plane, IOP, angulation, the machine is going to tell you good, bad, you can do it any number of times, so I won't spend too much time here. So the advantage again is the trainee can assess their own competence, and if there's a feedback from the trainer, it's even better. They can really focus on where they're lacking. Now this is coming to my core topic, so I thought I'll add something here. This is all about cataract. Maybe there are some simulations maybe for vitrectomy also. But what about other procedures? There's so many things you're doing. Lid tear repairs, entropion, ectropion, DCR, squint. Where the hell are you going to learn this? Okay, so till we have better simulations for the other, this thing, I'd like to tell you that we have something called as fresh frozen cadaveric dissection. Okay, you might wonder how this is different from the cadavers we used in the anatomy lab. So those are preserved in formalin. They are so shriveled, the tissue loses its original feel. Also, there are embalmed cadavers, but what I'm talking about and what we have in our institution is fresh frozen cadaver. So that is next best to operating on a live person. So this is how it is stored. It's a deep freezer. It is the body immediately after death. Nothing is done to it. Okay, it is just stored at minus 20 degrees centigrade. And before we use it, it has to be thawed for 3 days at 4 degrees centigrade. And this is how we plan our module. We've been doing this for 3 years. So initially, when we get the date for our Ascend lab, we plan all the surgeries. Around 25 surgeries we perform on one cadaver, and we are given only 1 day, so we really maximize our resources. So the training starts a couple of weeks before, wherein both the anatomy and the surgical procedure is discussed. So there is peer learning and there is a facilitator also, faculty who discusses. We touch each and every aspect again. We again go through sterilization. We go through arranging the trolley and the various instruments that are used. Then in the module 2, we make them do wet lab for all this all over again. And then finally, this is the advanced surgical skill lab. Okay, so here, we mimic the actual OT. So you can see everybody in scrubs, etc. And before this, what we do is we give them a checklist of the common surgeries they are going to perform. Each PG performs at least 5 procedures. So we tell them, this is how we are going to evaluate you. They go through this checklist beforehand. And like I was mentioning, just see the kind of procedures we are able to do on a cadaver. Litter, tarsorrhaphy, ptosis. Recently, I marked this in red because even orbitotomies we did in the skill lab, and we were actually able to perform, we removed an orbital mass after this. This is what the faculty did. So that is the kind of exposure. And the next picture you will see, this is the LPS. Okay. So can you see how clearly we can make out the tissues? It is literally like operating on a live patient. So you see hooking of the muscles here, and lateral rectus recession, lateral canthotomy. So, and after this, what we do is, during the procedure, the faculty will evaluate the students while they perform. Then at the end of it, we take a feedback from the student, because each year we want to improve. We want to know, how we can improve on this. And after this, when the PG actually gets cases, they may be small cases like DCT or chalazion, but we assess them stepwise because they've been trained stepwise earlier. So here are some more tips that I'd like to give. So many times in the OT, what happens is everybody, especially the PG, is focused on getting the whole case. So please don't do that. So you focus completely on one step at a time, getting it right. Then I also wish to say that you must learn from the best. The more skilled the surgeon is, the more senior he is, actually you should learn from them. Make them, request them to assist you. And always use good microscopes and good instruments, otherwise it will bring down your confidence. If you can't see, you think you're at fault, you think you're not a good surgeon. But beginners need good instruments. Always do your best to record your surgeries, go through them multiple times, and it's very, very important to reflect. Now, this is something we follow for our postgraduates. There is a reflection form given to them after every case they do, no matter how small a step. So they will say what went right, what went wrong, and whoever is assisting them will give them marks for each and every step they have done. Then they'll go back, read, and work on it. And this is usually discussed before their next case, so they don't make the same mistake again. Again, a very important point is PGs should choose an ideal case. And what I mean by ideal is the vision in the other eye should be good, and the ocular exposure should be good. You don't want very prominent brows and then struggling, or a very small eye and the PG struggling. Also choose the grade of cataract. Don't go for a very hard cataract, because nucleus delivery may become difficult and you may damage the cornea. So pupils should dilate well. And things like ability of the patient to lie down for a long time, and also would be very helpful if you know the language of the patient. It makes a huge difference for the patient to cooperate, when things are a little shaky. Then also there are rubrics, okay? So to ensure that beginners meet a certain standard of performance, a standardized internationally valid tool such as the ICU Ophthalmology Surgical Competency Assessment rubric is useful. So during your sim also you can use, and perhaps you can also do the same, you can assess the student when he's doing the actual steps, so that you know whether he's a novice, is a beginner, or he's competent, and accordingly you can give him more steps and more independent cases. Okay, so this is what it appears like. I would request the teachers to go through this and try to train your PGs in this fashion. So as it was mentioned earlier, it's also important to have a good physique and posture for extended work hours. Very important that you must have passion for learning and to help patients. And I would love to stress, okay, on this point, you have to learn to endure failures. We can't have great days always. And most of us get very disheartened when we have a failure. So I think it's important to train them how to endure failures. And I would say many times you need prayer, not sometimes. And also to develop a good clinical judgment. It's not a very easy thing. So as Lord Smith who was the past president of Royal College of Surgeons of England, once put it, it would take me 1 year to teach a trainee how to do an operation, 5 years to teach them when to do the operation, but a lifetime to teach them when not to do an operation. And I think it's a very important thing we should know, especially in the beginning of our career, what not to touch. So how much is actually good enough? Okay, so in one paper that I came across, they said in UK they insist that the residents must do 350 surgeries before completing residency. In US they say it should be at least 86, okay, independent surgeries. And in India they say it's good to have 50 phaco's and 50 SICS, but there's no minimum mandated number. Maybe this is something that we should work on. Training must be more proactive, but at the same time, we have to remember that it has to be self-directed and reflective, because it's all about learning. Nowadays, what we do is teaching. It has to be more of learning. That means the student has to feel the need. And again, this quote I really like because it makes a lot of sense. Under pressure, we don't rise to the level of our expectations. We fall to the level of our training, and that is why your training has to be solid. So coming back to Mr. Duja Pujari, so if the postgraduate, without having done his wet lab, his studying the procedure, not keeping the sterility measures, goes ahead and operates, so Duja Pujari will always remain blind, and his grandson will have to discontinue his school. Because remember, I told you that mishap where he lost all the members of his family. So if the grandson stays back to look after him, there's no school for him. So with this, I hope I've given you some tips for building confidence before competence. It was more like chicken or egg of a thing for me. But since the topic was confidence before competence, I thought this is the best way I could put it. So thank you once again for giving me this opportunity. Happy teaching and learning. Thank you.
Thank you, Dr. Sheetal. Now we know it's okay to be clumsy at first, as long as we keep taking the next step towards becoming surgeons. May I now request Dr. Devika to present to Dr. Sheetal.
Start